My name is Richard Tisdall. I'm a landscape architect by profession, but in recent years we've been exploring more and more the relationship between parks, landscapes and health. As part of that journey, which we'll touch on more a little later, I've looked into Masters in Public Health, done some epidemiological research, and explored what the evidence says about the subject area, and also what we can do about it on the ground. It's fine to have the academic research, and we need that. It's great to have the policies, but at the end of the day, if we're going to make a difference in our communities, there need to be practical outcomes that we can actually bring about and deliver. And that's very much what this talk is about. So primary prevention has been talked about earlier, and as we've touched on before, and this goes from a 2018 report, government report, prevention is about helping people stay healthy, happy and independent for as long as possible. This means reducing the chances of problems from arising in the first place. And when they do, supporting people to manage them as effectively as possible. Prevention is as important when you're 70 as it was when you're 7. And in 2019, Matt Hancock outlined the NHS 10-year plan, which really emphasised the importance of prevention for the first time, and also allocated funding for prevention in terms of mental health, 2.3 billion, and 4.5 billion for GPs and community care. And this is going to change the estimate of 150,000 less heart attacks, strokes and dementia cases, and 55,000 more people surviving cancer each year. And so for the first time, there's a fundamental and profound shift from the delivery of clinical solutions to prevention. Why? And just 3 figures here from the general figures that you'll be well aware of. 70% on the treatment, the medical treatment of avoidable ill health. Adult and social care, which is particularly important for local authorities, it's a big cost. It comes in at 20.4 billion. And the loss to the exchequer from workplace stress, anxiety and depression is at 64 billion. These are big figures. And therefore, if there's a way of bringing those down or reducing them, slowing their increase by prevention as opposed to treatment, while it's a longer term solution, it's a much more sustainable solution. And then the question comes, how then do we use our parks and open spaces within primary prevention to reduce these costs? Can we do that? And if so, how? There's an estimate from the Public Parks Committee report that there are at least 27,000 parks in the country. They're there creating valuable amenity and landscape and resources. But by and large, they're not perceived as part of the prevention story. It's rather like, you have a spare room in a house or a building, and it's all locked up, and you go and look at it occasionally, but you're not using it. And it's lost revenue, it's lost value. And therefore, what we've explored is how can we actually change that? How can we bring our existing parks and open spaces into use within that context of primary prevention? The first thing I'd suggest is that we need to change our mindset of what parks and spaces are. And historically, they're seen as amenity areas, landscape areas, good areas, but they're seen as a cost. And I would suggest that as an alternative, we need to start seeing them in terms of public health. And so the first question is, how do they fit into the story of public health? How do they fit into that mindset? And I'm a landscape architect, I work with developers, we work in the planning context. The whole concept of public health was foreign to me and to many of us, and why not? We've never been trained in it. Did the public health masters there. There was no way I was going to actually know about public health. But increasingly, I think as professionals in councils and in work, opportunity in these days to broaden our mindset, to broaden our awareness, to realise we're part of a bigger solution, a part of a bigger team, which has been touched on a lot earlier, and to start contributing to that bigger story of primary prevention. And so first of all, just briefly, I'm going to run through some of the key principles of public health. First, of course, is addressing issues upstream, and many of you will be familiar with the upstream, downstream context. That the story goes that there I am standing by the river, and I hear a cry, and I look over, and there's someone in the river floating down, crying out, waving their hands, crying for help. I leap into that river, and I drag them, and I do artificial respiration, and I call the ambulance, and they're taken to the hospital. And just as I'm recovering, I hear another cry. And I look across, and there's someone else in the river. And I leap in again, and I drag them out. And we go through that again, and then I hear another cry. And again I do it. And eventually I stop and I think, well, who on earth is throwing all these people in? And the issue that we have is that problems are being created upstream, but being dealt with downstream. And so the first principle, in the sense we would explore, is that how can we use these parks and open spaces upstream as part of the solution, rather than treat people downstream when they've already got a condition. And these are avoidable conditions. The second aspect of public health is the evidence base. And the question crops up, is there evidence to support the use of green spaces for health? And clearly there is. This is just information drawn from William Bird some time ago in an early report he did, that found that reduced access to green space obviously reduces physical activity. It can be associated with social isolation, obesity. These factors then work through into stress, anxiety and depression. Those then work through into what he calls, and medically is known as raised inflammatory markers, and they then have an effect in generating heart disease, diabetes, cancers, hypertension and stroke. Now there are two things here. The first is that there is a link scientifically between parks, open spaces and health. The second thing to bear in mind is that there are morbidities, but there are comorbidities. In other words, there are related conditions that in a sense you'll find that perhaps overweight, obese, will have a greater propensity for depression. Those who are depressed are less likely to do physical exercise. Those who are less likely to do physical exercise are more likely to start developing medical conditions. And so whilst the emphasis is a lot on physical activity, I'd also bear in mind what Andy Burnham was saying earlier, that the mental health issue is the same, because all conditions are actually linked. And therefore, in terms of delivering on open spaces, green spaces, across the health spectrum, we need to bear in mind we are dealing with all those conditions. The next concept is that of determinants of health, the causes of the causes. And Dahlgren and Whitehead in an early paper established the social determinants of health. And at its centre, as you'll see, there's hereditary and personal issues, factors, social community networks, living and working, and then the wider socio-economic issues. Because in a sense, the avoidable conditions, you would say, what has caused diabetes, what has caused cancer, what has caused heart disease? There is a medical answer to that. Sugar levels in diabetes, for example, insulin. Right? The bigger question, and that's the cause. What is the cause of the cause? And a lot of those go back to determinants of health. So not only are we dealing with what is the evidence base, than that perhaps, and to our saying, I don't just want to treat this condition, and we do want to treat it, medically if necessary, but as those involved in the urban spaces and parks and green spaces, those with a responsibility and a desire to improve health of our communities, how can we deal with the causes of the causes and create a positive environment? The health map. And this is the interpretation of the social to the physical environment. And again, people, lifestyle, community issues, the local economy, activities, the built environment, natural environments, and the global ecosystem are all, in a sense, determinants of health in the physical environment. But it's really interesting to see how many actually link across the green spaces. So there's the perception of landscapes, there's diet, there's growing food, there's physical activity, there's work-life balance. To develop social capital, social cohesion. Crime levels go down and the quality of the environment comes up. Greener areas are more prosperous. Parks are places for moving, playing, learning. Context for the 5 ways of well-being. And then addressing issues like noise and pollution. And the environmental dimension as well, in terms of carbon capture, sequestration, the heat island effect, reduced temperature extremes, UV shade, biodiversity. And therefore, based within the public health model, parks respond very well in being part of a solution to this problem. The 5th aspect is that of health promotion. And again, this has to do with how do we use our parks. So there's the physical dimension, how can we create our parks from a health point of view. But the second is, that we touched on a bit this morning, how can we actually use our parks from a health perspective. And there are many others, but 2 in particular, community initiatives. And they may address medical issues in terms of data, behaviour change, education, empowerment, social change. And as we touched on earlier again this morning, social prescribing, a means of enabling GPs and other frontline healthcare professionals to prescribe non-medical interventions, which often utilise services provided by the voluntary and community sector, as we were touching on earlier today. And those together are some of the key principles of public health. And in terms of social prescribing, obviously Manchester itself is well ahead of the game. This is just from the information from the voluntary organisation. And if I can read it down here, that 90% of health problems are affected by the patient's well-being. Social prescribing can be an alternative to clinical interventions, in effect. And it's coming up the agenda. And therefore we have parks physically that can be used for health, but also has a location for health in terms of community initiatives, social prescribing. Another one I was thinking of adding in, is that of workplace well-being, projects from the workplace. And there's a strong economic case. Again, as we heard earlier, that 34.2 billion a year is saved by the NHS through parks, 111 million per year through green spaces. There's a strong economic case, not simply in terms of the costs, but also in terms of the overall use of funding in the community. So that in a sense is the background, and many of us are familiar with that. The big question is, what do we do about it? What do we do about it? It's the how are we going to make a difference. And something we've been working on is what we've called the Parks for Health initiative. And it has a number of characteristics which I will begin to go through. But this, in effect, is a practical toolkit that people can use to assess their parks for health. It links the evidence base, what research has found, through to what that looks like on the ground, and then is put in a form where people can use the subsequent questionnaire, which we'll come to actually assess and make conclusions about the health characteristics of their parks. And this looks at 5 primary criteria, some 17 secondary criteria. The primary one being community initiatives, or social prescribing initiatives, if you will, accessibility, mental well-being, physical activity, and environmental factors and biodiversity, all of which have an effect on health, which is why earlier on I touched on the importance of not simply looking at physical activity, for example. How can we put more physical activity into our parks? but the whole mental side, mental well-being side as well, accessibility, community initiatives. And also we know that increased biodiversity itself has a positive effect in reducing stress, and that gives us another dimension to actually, can we increase the biodiversity of our parks? Can we use them to address sequestration, carbon capture, reduce temperature extremes, all of which have an effect on health. And so the initiative is a practical toolkit which is available and can be used. Where did it come from? It came from, as landscape architects, we deal with sustainable development, and we started exploring how do we design for health and well-being. But that gradually became not an emphasis, but it sort of diversified into how can we actually assess and create healthy places. And as we know from the NPPF, the social dimension is as important as the economic dimension or the environmental dimension. We also know that communities that are not healthy are not sustainable, though they may be economically and environmentally. If the people are ill and dying prematurely, this is not sustainable. We explored public health, as we've touched on, and then we started developing the assessment model. And the assessment model had to have certain requirements. The first, it had to be public health, which we demonstrated. Green space and public health mesh very well together. It had to be evidence-based. It had to be objective, quantifiable, replicable, and suitable for a whole wide range of applications and users. What we had to avoid is the tendency all landscape architects will go into, and I put my hand up here, is that we like certain kinds of environments and therefore we think they're good, which is why you get complete different design solutions. And therefore the toolkit, the assessment model, had to move aside from that. It had to be objective. Okay? And that was important. We then went through the process of understanding what public health was, as I've touched on, reviewing the evidence base, categorizing the evidence base, and that was a lot of papers. But we began to categorize them in terms of broad criteria, and this is the framework that's evolved from it. Health promotion, accessibility, mental health, physical activity, environment and biodiversity. 17 secondary criteria within those, and also landscape elements. We then had to interpret the evidence from a landscape perspective. So for example, if the research found that access and views of the natural environment was reduced stress, which it does, what does that look like on the ground? It looks like biodiversity, it looks like habitats, it looks like trees, copses, woodlands, meadows. That broad range of biodiversity, we could begin to address that particular part of public health. What does physical activity look like? Obviously we're more familiar with that. It looks like sport pitches, play areas, walking routes, cycling routes, community initiatives, we'll touch on in a little bit. And so what we began to do was actually ask the question, what does health look like on the ground? From that we created a questionnaire and linked those to two things. First, to the primary and secondary criteria that we've talked about, but also through the nice guidance for the treatment of different clinical conditions, we were able to begin to link those things by association to obesity, non-communicable diseases, mental ill health and environmental factors. And so what we've gradually been able to do is to build up a picture of how we can actually assess and then develop parks against both the evidence but also with the